Dear colleagues, thank you very much for inviting me. It's great to be with you. My name is Marcus. I'm here in Berlin at Charité, and I'm very happy to discuss with you future perspectives in chronic spontaneous urticaria and chronic inducible urticaria treatment. These are my conflicts of interest. And before we start to talk about what the future holds, let's see where we stand today. In chronic urticaria, defined as wheals, angioedema, itch for longer than 6 weeks, we distinguish between chronic spontaneous and chronic inducible urticaria. And all of chronic urticaria is heterogeneous. It's a common, disabling, very long-lasting, and often poorly controlled disease. So clearly we need better treatment options, especially since we say that the goal of treatment in chronic urticaria is to treat the disease until it is gone. No more wheals, no more itch, no more angioedema, and clearly we need good treatment options to achieve that in all of our patients. Do we have these treatment options today? Well, not quite. We have very few treatments. We have antihistamines and omalizumab, and where this doesn't work, cyclosporin and other off-label treatment. And that can do a good job in many patients, but it is not sufficient to help all patients to achieve the treatment goal. How do we achieve the treatment goal? We use the urticaria control test, and we on a regular basis measure disease control with this test. And when the test, which ranges between 0 and 16 points, has less than 12 points, this means that we need to increase our treatment efforts. We need to do a better job to bring control to the patient. So it's a call for action. And when patients achieve 12 points or higher in this test, well, then that's good, but not perfect. Perfect is 16. That's complete control. This is where we want our patients to be. And this is then also where we can start to think about reducing treatment, but not before. We need to achieve control and then see if we can maintain that control with the treatment that we have. How do we do this today? I do this with the app Cruise in all of my patients. Here is the QR code. You can download it now and check it out and see what it does. It's a very simple app. It's very nice for patients to document their daily signs and symptoms. So you will get the urticaria activity score, the angioedema activity score, but you will also get the UCT, the urticaria control test. And patients who use Cruise can send this information to you so that you can adapt the treatment accordingly. Now, if we want to develop, and we do, better treatment options for patients with chronic urticaria, we need to understand what drives the disease. So let's review. Chronic urticaria is a mast cell driven, a mast cell dependent disease where mast cells that get activated in the skin release mediators, pro-inflammatory mediators, including histamine, that then activate the sensory nerves, the blood vessels, and recruit other cells to form the signs and symptoms, the itch, the erythema, the wheals, and the angioedema, and when you look inside these lesions, also the infiltrate. Today, when we look at how well we understand chronic urticaria, what do we have? Well, we have few treatment options and many patients with uncontrolled disease, so there's a high unmet need. And what do we need? Well, we need better treatment, targeted treatment, and especially treatment for chronic inducible urticaria, where all we really have today are antihistamines, as omalizumab is not licensed for chronic inducible urticaria. In chronic spontaneous urticaria, we especially need treatment for those with autoimmune chronic spontaneous urticaria, where IgG autoantibodies that activate mast cells drive the disease. So let's look at the drivers of chronic urticaria. Let's look at our understanding of the pathogenesis, because These drivers, as much as they drive the disease, are targets of novel treatment options. We know that mast cells are in the center of the pathogenesis, and we know many receptors on mast cells that activate mast cells. We know the signal transduction that is downstream of these receptors that translates the receptor signal to degranulation and the release of mediators. And we know many mediators that come out of mast cells that contribute to chronic urticaria. Now, upstream of mast cell activation, it is autoantibodies. Autoantibodies and cytokines that drive mast cell activation. So we know that B cells and T cells are involved. And downstream of mast cell activation, it is eosinophils and basophils that contribute to the lesion formation and the signs and symptoms. So these drivers of disease also are the targets of emerging therapies. And in addition, we know a couple of inhibitory receptors that we can engage in order to silence mast cells. So let's look at the emerging therapies. And in my head, it's all about the mast cells in 4 different ways. What we can do in a mast cell-driven disease like chronic urticaria is we can inhibit mast cell mediators. We can inhibit what comes outside of mast cells and drives the signs and symptoms. And in a way, that's exactly what we do with an antihistamine. Histamine comes out of mast cells, is a mediator, and we inhibit it. Number 2, we can inhibit pathways of mast cell activation. When we stop the activation of mast cells, they no longer cause wheals or itch or angioedema. And in a way, this is what we do with omalizumab. We block IgE and IgE receptor mediated activation of mast cells, and it works, but not in all patients. More novel treatment approaches aim at silencing mast cells, shutting them up, or depleting them, killing them. We will talk about all 4 of these treatment approaches, but I will put a special focus on those treatments, on those approaches that are farthest developed that will come into our clinical practice soon. And let's start with the inhibition of mediators. What mediators come out of mast cells and contribute to the disease? We know that it is cytokines, 413, in autoimmune chronic spontaneous urticaria 17 and 23, and we know it's histamine. But histamine acts on 4 receptors, and currently we're only blocking one of them, the histamine 1 receptor. So current programs look at blocking histamine and its effects on the H4 receptor. Let's start with IL-4 and IL-13, where dupilumab blocks both of them. You know dupilumab, it's a treatment for many diseases, including allergies and skin diseases. And this clinical trial shows that it is effective in chronic spontaneous urticaria. It reduces the urticaria activity score. It reduces both components of the urticaria activity score. On the left, the itch, the ISS, itch severity score, and on the right, the wheals. So this mechanism of action is effective in chronic spontaneous urticaria, but why? Do we know how dupilumab works in chronic spontaneous urticaria? Well, we have some answers, and one of them may be that dupilumab treatment reduces IgE. We know that IgE is a validated target. We know that anti-IgE, omalizumab, ligelizumab work in chronic spontaneous urticaria, but they don't reduce the IgE production. They capture IgE. They don't downregulate IgE levels by acting on its source. Well, dupilumab is held to do that. And within 24 weeks, you can reduce the IgE levels, the IgE production, to about half. Now we know that dupilumab works in patients with normal IgE levels, so less than 100, as well as in patients with more than 100 IgE. And this is true for, on the left, the itch component of the USS, as well as on the UAS. So with this information, dupilumab is now on track to be licensed as a treatment for chronic spontaneous urticaria, and we do hope that as early as next year, we will have dupilumab as a licensed treatment option for patients with chronic spontaneous urticaria. Let's go on and look at the inhibition of activation. The inhibition of activation needs to target pathways of mast cell activation that are relevant in chronic spontaneous urticaria. We know that IgE and the IgE receptor is a valid target. We know this from omalizumab, and we know this from ligelizumab, and novel anti-IgE or IgE targeting treatments are under development. TSLP is an alarmin that drives type 2 chronic inflammatory disease, like in chronic spontaneous urticaria. The study is completed. We're looking forward to results coming out real soon. C5a and its receptor on mast cells is a pathway of mast cell activation in autoimmune chronic spontaneous urticaria. So we're looking forward to the first study that explores anti-C5a or anti-C5a receptor treatment in patients with chronic spontaneous urticaria, especially in patients with autoimmune chronic spontaneous urticaria. And then there's a very interesting, intriguing receptor, MAS-related G protein coupled receptor X2, or X2 for short, and this is localized on mast cells, preferentially on skin mast cells, and it's the receptor that translates many ligands, exogenous and endogenous, to mast cell activation. Many drugs act on mast cells and cause their degranulation via X2. And many neuropeptides do this as well, substance P, for example. We know that substance P is elevated in chronic spontaneous urticaria, and we know that the substance P levels are linked to disease activity. So we are waiting for the first trial to look at X2 antagonists and their effects in chronic spontaneous urticaria. But I want to focus on the signal transduction machinery in mast cells that translates receptor engagement to mast cell activation. And I want to look especially with you at BTK. BTK is Bruton's tyrosine kinase. And if you're interested in what BTK does and its inhibition, then I invite you to read this recent paper where we look at the therapeutic implications of BTK inhibition across several dermatological conditions, including chronic spontaneous urticaria. So let's look at BTK a little bit more closely. What does it do? Where is it? BTK is in mast cells downstream of the IgE receptor. And when the IgE receptor is activated, for example, by IgE and autoallergen or by IgG against Fc epsilon R1, well, then the signal transduction machinery starts to translate this engagement into mast cell degranulation. And a key feature, a very important, maybe the most important signal transduction molecule that does that is BTK. But that's not all. BTK is also in B cells, in plasma cells. Plasma cells produce autoantibodies. Autoantibodies produce chronic spontaneous urticaria. So when the B cell, the plasma cell, is stopped because BTK is inhibited, the production of autoantibodies is reduced. We have two BTK inhibitors currently under development, remibrutinib and rilzabrutinib, and I will share with you a little bit of information available on remibrutinib. The rilzabrutinib study is still ongoing, but we hope to see results soon. Before I do that, I want to talk about another BTK inhibitor, fenebrutinib. Why? Because the clinical trials with fenebrutinib in chronic spontaneous urticaria have been successfully completed. This is the study that shares the results of fenebrutinib, which is no longer developed for chronic spontaneous urticaria due to a safety signal. But the clinical trial shows very good efficacy. Let's look at it. 3 different doses of fenebrutinib, here the colored lines, and placebo were given to patients with chronic spontaneous urticaria for 8 weeks. And you see how fast the disease activity goes down with the different doses of fenebrutinib. The interesting thing is that it's not just the disease activity that goes down, it is also the IgG mast cell activating autoantibodies. And you see that the levels of these autoantibodies for the 3 doses of fenebrutinib are lower than for placebo, reduced by 50%. So quite a bit. And this is the kicker, when you correlate the UAS7 change on the y-axis, that's the improvement, with the reduction in IgG anti-FcεR1, those are the autoantibodies, well, then there's a strong correlation. In other words, the more you reduce the autoantibodies, the better the clinical response. Now for remibrutinib. Remibrutinib is going strong. Phase 3 is completed. We're looking at this drug coming to us as early as next year. Why? Because it is very effective. And in the phase 2 study that I'm showing you here, 6 different doses of BTK were tested against placebo. Here are the results: very fast reduction in disease activity, a sustained response across the treatment time, also a dose response, and maybe most importantly, a good effect in patients who had previously received anti-IgE treatment without effect. Now you see the solid bars reflect the reduction in disease activity across the 6 different doses in patients who had previous anti-IgE treatment, and the other bars are those who did not. So it is effective in patients with or without previous use of omalizumab. We also know that the proportion of patients who become complete responders can be up to 50%. And it's especially so for patients who did have previous use of anti-IgE. So here may be a treatment that works better in autoimmune chronic spontaneous urticaria as compared to non-autoimmune chronic spontaneous urticaria. Let me come to 2 more approaches. Mast cell silencing. How does that work? What is that? Well, mast cell silencing requires knowledge of a silencing receptor. And yes, mast cells have silencing receptors, inhibitory receptors. Siglec-8 is one of them. And when Siglec-8 is engaged, then this produces an inhibitory signal. And we have antibodies that can do that. Lirentelimab is one of them. This is one of them. When lirentelimab binds to Siglec-8, it inhibits mast cell activation by other mechanisms, including IgE receptor, but also others. Does it work? Well, we performed a study and saw that lirentelimab in omalizumab-naive patients reduced disease activity in chronic spontaneous urticaria by 75%. And even in patients who were omalizumab refractory, lirentelimab reduced disease activity significantly. And in this very trial, patients with symptomatic dermographism and cholinergic urticaria, so chronic inducible urticarias, also benefited. Currently, there's a study ongoing with lirentelimab in chronic spontaneous urticaria. Our fingers are crossed. This would be a very nice additional novel and elegant way to reduce disease activity in chronic spontaneous urticaria and chronic inducible urticaria. As for the last approach, let's look at mast cell depletion. And for this, I need to step back a little bit and talk about chronic inducible urticaria. Why? Because the clinical trials that I'm going to share with you were performed in chronic inducible urticaria, the first ones anyway, and they were in symptomatic dermographism, the most common form of chronic inducible urticaria. Patients with chronic inducible symptomatic dermographism respond to scratching, for example, with a tongue blade or a ballpoint pen closed. And when you write on the skin of patients, you will see that this produces, in addition to red lines, which it does in all humans, wheals. This is 3 minutes, 4 minutes, 5 minutes, 10 minutes, and 15 minutes after scratching, a strong whealing response that shows us what this disease looks like in real life. Scratching patients, therefore, confirms disease. That's good. We should do that. But it does not allow us to measure disease activity. To measure disease activity, we need a dermographometer. There are several dermographometers. The bottom one is called Frick test. And with this Frick test device, you can do threshold testing. In other words, you can ask, how strong does the skin of the patient need to be scratched in order for a wheal to occur? The 4 pins provide different strength, and someone who produces a wheal to all 4 of these pins has high disease activity. Someone who only produces 2 wheals to the 4 scratches has moderate disease activity. So here's a way that allows us to measure disease activity in symptomatic dermographism. What about cold urticaria? Every cold urticaria patient with typical cold urticaria will get a wheal when you put an ice cube on the skin. Does that tell us something? Yes, of course, it tells us that the patient has cold urticaria, but it doesn't tell us how sensitive this patient is, what the disease activity is in this patient. For this, you need temp test. This is what temp test looks like. It's a box with a thermo element that produces all temperatures from 4 degrees Celsius to body temperature and even higher, so that you can expose the skin of your patients with cold urticaria to these temperatures. And patients will respond to the temperatures that for them are cold enough to produce a wheal. And you can see the length of the wheal reflects the disease activity, reflects the threshold. In this patient, close to 27 degrees. In this patient, 24 degrees. So now let's come and use this knowledge to look at what happens in symptomatic dermographism and cold urticaria when you deplete mast cells. Does the temperature threshold, does the scratching threshold, do disease activity and the impact of the disease go down? Mast cells need stem cell factor to survive, and they take up that stem cell factor by a receptor called KIT. When you prevent this from happening by blocking KIT and therefore SCF binding, mast cells will go into apoptosis. They will die. They will no longer release a little bit of tryptase, which is their signal of, hey, I'm still alive. So what happens when you do this in patients with a mast cell-driven disease? Let's look at chronic inducible urticaria. 1 injection at day 0 of barzolvolimab, that's the antibody that blocks KIT, reduces disease activity dramatically and very fast. It reduces it so much that patients no longer respond to the cold with wheals. Barzolvolimab, again, one injection also reduces disease activity in symptomatic dermographism. 3 milligrams per kilogram body weight given once. Within days and weeks of this injection, we have no more disease activity. Patients no longer respond to scratching with wheals. In fact, this is a complete response where all or virtually all of the patients are completely protected from their disease. Why? Because we reduce dramatically the number of mast cells in the skin. We kill them. And this is also reflected by the reduction in tryptase levels, which are down and stay down. The same thing happens in chronic spontaneous urticaria. 4 different doses, blue not enough, gray is placebo. But if you give high enough doses, you reduce disease activity, urticaria activity score, and you increase control. Bring patients up to 16 points or at least more than 12 points well-controlled disease. And this happens in orange and black in OMA-experienced patients and OMA-naive patients, respectively. So these are very interesting and very promising treatment options. We can inhibit mast cell mediators that we cannot inhibit today. We can inhibit mast cell activation, different from what we do today. And very new, we can silence mast cells and deplete them. So, the emerging future treatments for chronic urticaria, and that's chronic spontaneous urticaria and CINDU, they are mast cell targeted. They are endotype specific or broad, and many of them are well advanced, with some of them in phase 3 studies already. So what we have to do is guide patients to these studies where they can already benefit from these treatment options and look forward to having these novel treatments in our clinical practice. Now, if you want to help to increase our knowledge of the disease, then please check out what the network of Urticaria Centers of Reference and Excellence is doing. This is our website. We have a registry, Cure. You're very welcome to join this registry, and we have very interesting meetings. So if you have no plans for the first week of December, do come to Sao Paulo for the UCare conference and join us there. And with that, thank you very much again for having me and also for your attention. And I'm looking forward to your questions. This is the Urticaria Center of Reference and Excellence in Berlin. I put my email address on the bottom right. So if there are questions that we don't have the time to answer today or that come to you tomorrow or next week, by all means, send me an email. I'll be looking forward to hearing from you. Thank you very much.